This is an LXMO presentation slash study slides for the exam. So the first slide, we'll talk about X-ray production. The essential parts of making X-ray are a vacuum, a source of electrons, a target, and a high potential difference between voltage of the electron source and the target. The source of electrons in an X-ray machine are the filament, which is made of tungsten. This is a metal element that has a large atomic number with 74 electrons in the orbit around its nucleus. The principle is that heat speeds up the electrons, speeds up the movement of electrons in the orbit and increases their distance from the nucleus. Electrons in the outermost orbital shell move so far from the nucleus that they are no longer held in orbit and are flung out of the atom, creating an electric cloud, a process called thermionic emission. So the cathode, the negatively charged part, shoots electrons to the anode, which is the positively charged target. The anode is a hard, smooth, angled target made of tungsten as well. When the electrons hit the anode target, it creates energy, 99% of which creates heat. The other is X-ray radiation in the form of photons. This Brem's radiation is created when an incoming electron is suddenly slowed down, changes direction, and leaves the tungsten atom. The kinetic energy of the electron is converted to an X-ray photon. Tungsten has a high melting point, which allows it to last through thousands of exposures. When heated, the outer shell electrons are freed and released. Thermionic emission is produced. When the electrons strike the anode, 99% is turned to heat. The other is Brem's energy. The rotating anode is positively charged. Again, the anode is positive. Cathode is negative. The cathode shoots the negatively charged electrons to the anode. The actual focal spot is on the anode. It's the angled target where X-rays are produced. The prep ready button initiates the rotation of the anode and applies heat to the filament to create the source of electrons. Radiographic tubes typically have two filaments, a small and a large one, which allows for selection of different focal spot sizes. The smaller filament produces a small focal spot, which gives high spatial resolution but lower X-ray intensity, whereas the large focal spot is used for larger body structures. The focusing cup on the anode is a negatively charged device that helps prevent the electrons from spreading beyond the target. The actual focal spot is the area of the anode where the electrons strike. So the small focal spot are used for most body parts. The large filament and the large focal spot strikes a larger target area for more dense tissue. The size of the effective focal spot determines image resolution. The steeper the angle of the anode, the larger the difference between the actual and effective focal spot. So a large anode angle of 20 degrees is going to produce a larger focal spot, effective focal spot, than a small anode angle of 10 degrees, which will have a small effective focal spot. The average angle of the anode is 12 degrees in most X-ray machines. The size of the effective focal spot determines image resolution. The relative size of the effective focal spot is determined by the target angle. The steeper the target angle, the greater the difference between the actual and effective focal spot. And again, Brem's radiation is the sudden deceleration of electrons. Energy when an electron is decelerated. Brem's radiation, also known as Bragg radiation, type of electromagnetic radiation emitted when a charged particle, typically an electron, is decelerated. Electrons are slowed down, they change directions, and they leave the tungsten atom. Kinetic energy is produced in the way of a photon. BREMS occurs at the anode, produces 100% of the photons when the kVp is below 70. Above that, BREMS accounts for 85%. The rest would be characteristic radiation. Characteristic radiation is when an inner shell K-shell electron is ejected and a higher energy electron drops down to fill the vacancy in the inner shell, emitting a discrete characteristic energy, X-ray, or a photon is produced. And again, characteristic radiation, when there's high kV, created when an incoming electron interacts with a K-shell electron and knocks it out of its orbit. When the electron void is filled with an outer shell electron, an X-ray photon is created. Compton's interaction is a phenomenon where a high energy electromagnetic radiation, like X-rays and gamma rays, interacts with electrons and matter. Photoelectric effect with true absorption. The photoelectric effect involves complete absorption of an incident photon by an electron, resulting in the ejection of an electron from the atom. The key element in X-ray production is the slowing down of high-speed electrons, BREMS radiation. The X-ray tube, the device designed to accelerate electrons and direct them towards a target material to generate X-rays. So for X-rays in general, the order from the least amount of energy, which has the longest wavelength and the lowest frequency, radio, TV, microwaves, infrared, visible light, ultralight, then X-rays and gamma rays. Gamma rays and X-rays are very similar, but gamma rays originate from radioactive elements. All electromagnetic waves travel the speed of light. Again, the actual focus spot is on the anode struck by electrons. The effective focus spot, vertical projection of the beam. The size of the effective focal spot determines image resolution. And the size of the effective focal spot is determined by the target angle. The steeper the target angle on the anode, the greater difference between the actual and effective focal spot. For the atomic mass, that's a sum of the protons and neutrons. The atomic number is the number of protons in the nucleus, and that the periodic table is arranged by the atomic number. Anode heel effect. The anode heel effect can lead to a non-uniform image, especially in a large field size radiography. The anode side of the image may be lighter, less dense compared to the cathode side, and that's because when the electrons hit the anode, it bounces off, and you get a higher intensity away from the anode side, so a higher intensity on the cathode side than the anode side. So the side that gets less radiation, or the anode side, is going to be less dense. So that's why you want to put thicker anatomy towards the cathode side, where it's going to get more radiation. Again, the radiation bounces off the anode and goes toward the cathode side in the effective focal spot. This only matters when you're not using any collimation, when you're using the whole field at 40 inches or 72 inches. So again, just place the thinner portion of the body part towards the anode side. The maximum heat capacity of an anode is rated by the heat units. The heat unit produced by an exposure are determined by multiplying the kVp plus Ma plus time. To extend the X-ray tube life, you want to warm up the anode according to the manufacturer's instructions. Do not hold down the rotator switch for long periods of time. Use low Ma settings whenever possible. Use the low speed rotor whenever possible. Do not make repeated exposures during the tube limits. Do not use a tube when you can hear the rotator bearings call for service. So when we talk about density of an X-ray, that is controlled primarily by MAS. Density is the amount of exposure. Blackness or too dark would be overexposed, or black would be overexposed. A window level in the digital imaging post-processing can help adjust the density. The number of brightness levels is determined by the bit depth. The contrast is controlled primarily by KVP. So if you have long scale contrast, you have very low contrast, a very little difference between grays. So there's a greater number of shades. When you have short scale contrast, it's black and white. So short scale is high contrast. So there's a huge difference between black and white on the images, but there's less grays. So it's considered short scale. Less dense tissue will absorb less radiation, like fat. And the abdomen has low subject contrast, very similar densities throughout all the structures in the abdomen. High subject contrast would be more of a finger where there's a huge difference between soft tissue and bone. So KV and MAS. MAS is considered the number of electrons, the power, basically the radiation, amount of radiation. KVP is the speed of the electrons, the controls the beam quality. Now KVP and MAS will not affect spatial resolution or distortion. That is OID and SID. Both will affect receptive exposure, though. MAS is predominantly what causes the amount of radiation. So MAS primarily determines the receptor exposure. Doubling MAS will double receptive exposure. It's a linear. You should double MAS for every increase in 5 centimeters of thickness. Greater quantity of radiation, MAS is required to cover the background noise that covers the image to appear grainy. So if there's noise, it's grainy, you need to increase your MAS. This can be done with KVP or MAS, but MAS is directly proportional to the quantity of radiation. If the picture is too dark, it's considered overpenetrated. You want less MAS. To increase contrast, decrease KVP 15%, or for every decreased KVP 15%, you need to double MAS. With KVP, if you increase by 15%, you double receptor exposure, so you have to use a 15% rule. When the KVP is lowered by 15%, the MAS is increased by a factor of 2. And when KVP is increased by 15%, MAS needs to be divided in half. To decrease contrast, use grids and increase KVP. This is important with chest x-rays to get a longer, less contrast, longer grayscale. You want to increase your KVP, like with, for instance, chest x-rays. For hand stuff, when you want increased contrast, less KVP. Larger KV, less patient absorption, less MAS used. If you increase your KVP, there's more gray, there's less contrast. Lower KVP is more black and white, again, for a lower KVP for the hand. If there's excessive contrast, it's basically grayed out. There was a failure to penetrate the anatomy, so more MAS. So notes about contrast. The hand requires high contrast, high black and white. Requires low KVP, short scale contrast. The chest requires low contrast, so high KVP. Contrast is primarily controlled by KVP. An increase in exposure causes a darker image. If you have a model or grainy or spotty image, the KVP and the MAS is too low. You get too much fog or gray image, there's likely too much scattered radiation. Use grids and collimation. Distortion and magnification is affected by OID and SID. The more OID you have, the worse. High SID and low OID is ideal. You don't want too close SID. Spatial resolution is controlled by SID, OID, and focal spot. If you increase your SID, and you have a small focal spot, it's better spatial resolution. A small focal spot should be used for most body parts unless a huge thick patient. If the patient's in motion, you should shorten your exposure time. Quantum model is a gray image or a blotchy image. There's not enough technique, so you'd want to increase your MAS with quantum model. If SID is cut in half, intensity is 4 times. You need to increase your, if SID is cut in half, the amount of radiation intensity is 4 times as much, so you need to cut it off. You need to reduce your MAS when your SID is reduced. If you're going to change your MAS or time, you can set up a calculation where such that if you're at 200 MA for 0.00 seconds and now you want a 500 MA, at what time you would go 200 times 0.006 equals 500 times your new seconds in time, and then you multiply 200 times 0.06, which gives you 1.2, and then divide that by 500, bring that over as 0.224. So you set up, or 0.0024. So you set up the equation and just bring over the x, or divide by time. So basically the A times B equals the new A times the new B, and go from there. So the inverse square law describes the change in intensity that you have to compensate with when you get closer or move further away. It's like a flashlight. The closer you are, the more light you have. The further away you lose light, and you have to compensate by increasing the power of the light. So when you get closer, you can turn the power down. When you move further away, you have to turn it up. And the inverse square law helps you calculate that. It's if you get closer, you're getting closer, it's intensity 1 over intensity 2 equals distance 2 over, distance 2 over distance 1, so it flips. Whereas if you move further away, you get intensity 1 over intensity 2 equals distance 1 over distance 2, both squared. In general, when you move within a quarter closer, 25% closer, you have to double your MAS, double your intensity. Same with, I'm sorry, no, that's incorrect. So if the closer you get to if you get a quarter closer, 25% closer to your object, you have to decrease your MAS by half. But if you move further away, if you increase your distance by a quarter, you have to double your MAS. One example is if you're at 40 SID at 20 MAS and you increase from 40 to 60, you're going to have to increase your MAS. So the calculation comes up, you're actually double your MAS for a 25% increase in SID. And again, the closer you get, the less power you have to use. The further away you get, the increased power you have to use, and it's inversely proportional such that if you move 25% closer, you got to double. If you move 25% closer, you have to cut it in half. If you move away 25%, you have to double. Some other notes in SID and OID. SID, when you decrease distance, you double exposure. Less magnification with decreased OID and increased SID. So get as close as you can to the receptor and increase your SID. Going from 40 SID to 60 SID requires twice as much MAS. An increased focal spot, an increased OID, and less SID decreases spatial resolution. So the larger the focal spot, the larger the OID, and the less SID decreases your spatial resolution. For instance, half-inch OID with 60 SID has better spatial resolution than a 1-inch OID at 40 SID. A lateral cervical spine is normally taken at 72 SID. If done at 40 SID, the increased magnification and loss of spatial resolution. So you increase your SID. For a lateral cervical spine, you increased your OID, so you have to increase your SID. Two types of X-rays, digital versus analog. Analog's the old style where you had to process in a dark room, where digital X-rays have the advantage of faster processing, higher quality images, lower radiation exposure, and easier storage and sharing. the analog is old, whereas digital was introduced in 1983. So two types of or different types of digital imaging. Computer radiography uses a plate with a laser reader. It has a photostimulable phosphor that emits an electric signal that converts to an analog signal before viewing a monitor. So basically, these ones you have to put in a laser reader, and it stores phosphorus. These ones are sensitive to scatter, and they can have ghost images, so you have to erase these every night. The digital imaging is more direct. There's two types of digital imaging. There's a direct, which is a one-step process. X-rays are directly converted to electrical charge by a photoconductor, selenium. So one step is selenium. Doesn't require a scintillator. Whereas an indirect process requires the X-rays are first converted to visible light by a scintillator, such as silicone or iodide, and then the light is converted to an electrical charge. After the electrical charge is generated by a digital imaging receptor, it must be converted to an analog to digital converter with an ADC analog to digital converter. So indirect requires an ADC analog to digital converter, silicone and sesame iodide. The direct is a one-step process, and it uses selenium. So aspects of a digital image. Image is made of rows and columns of pixels. Each pixel has a numerical value shade of gray called quantization. Bit depth is the number of shades of gray available. Spatial resolution, ability to see small structures affected by matrix and pixel size. Del, detector that converts X-rays to electrical signals. Subject contrast is the characteristics of an object being X-rayed. Exposure latitude is the range of exposures that can produce an acceptable image. Each digital image exposure creates a histogram. It's automatically rescaled based on a lookup table. Lookup table is basically a bunch of stored images that the computer can reference. Exposure index, how much exposure the receptor received. So the exposure index gives you a good or bad grading. Window level helps control the density post-processing, so you can adjust the density post-processing in the computer viewer. When looking at an image, if there's not enough radiation, not enough exposure, there'll be noise or a quantum model. When you see that, you have to increase the exposure, increase the signal to noise ratio. If you have saturation, it's too much exposure. The amount of radiation hitting the image receptor is the receptor exposure or brightness. Quantization, the process of assigning a number bit value to a pixel. Pixel pitch is the distance from the center of one pixel to the other. Del is in cassetteless digital imaging, helps determine the spacer resolution. Detector element converts to digital imaging. Signal to noise is the description of useful information to useless information. Some other active terms. Histogram, the record of ranges of exposures in the exit beam. Lookup tables, predetermined acceptable appearance of all anatomical areas. Automatic rescaling, modification of actual data to display an acceptable image. Exposure latitude is a range of exposures that can produce an acceptable image. DQE is the detector quantum efficiency, and it determines the efficiency of detectors at converting X-ray energy to electrical signal. DICOM, standardization of gray images. It's an international standard for storing, transmitting, and displaying medical images. Assesses the quality of an image. The SMT pattern helps identify any inconsistencies or variations in image brightness and contrast across the display, ensuring the image is uniform. It's the universally accepted grayscale. High voltage transformer provides thousands of volts for X-ray production. In X-ray machines, a rectifier bridge is a circuit that converts high voltage alternating AC current to pulsating DC current that's needed to operate the X-ray tube. So DICOM basically sets the standard for grayscale images. Universally accepted standard for exchanging medical radiographic images. The SMPT is the Society of Motion Pictures and Television Engineers. So the DICOM is really what creates the consistency in grayscales. So again, the SMT, Society of Motion Pictures and Television Engineers, helps check viewing monitor performance, including distortion, luminance, noise, contrast, and resolution. Detective quantum efficiency, DQE, reflects how effective a detector uses incoming X-ray photons to create an image. It is essentially a measure of the signal to noise of the output image compared to the input signal. Refers to the variation in detectors which predict the efficiency in converting X-ray energy to electrical signal. Spatial resolution with flat panel detectors is primarily determined by Del size. Del stands for detector element, which is also known as a pixel. The size of the Dels or the pixel pitch directly impacts spatial resolution of the image. Smaller Dels generally lead to higher resolution, meaning more detail can be captured in the image. A moire pattern on a CE reader is artifact. Ghost occurs on the CR reader, computer radiographer, if it's not erased at night. Auto timing or automatic exposure control typically terminates the exposure when a predetermined quantity of radiation has been reached the sensors. Thus, time is longer with thicker parts and shorter with thinner parts. The sensor in the X-ray table detects when a given amount of photons have been reached, then terminates the exposure time. AEC, or automatic exposure, has 3 exposure fields or 3 locations. The knee will be, if you want the knee, or you're doing a knee, you want to choose the center detector, where the chest, where you'll choose the 2 upper detectors, and the detectors will be centered to the image receptor and the central ray. Patient positioning is crucial with AEC to keep the image receptor in the center. So, and then another technique is the anatomically programmed radiography, which is most X-ray machines today. Basically sets the MAS and the KVB based on body habitus. Again, anatomically programmed radiography. In terms of the rotator switch, which warms up the tube, making exposure before the tube is ready may damage the tube, so you have to hold the rotator switch, warm it up, and then hold the rotator switch down with when you hit the exposure switch as well. So when you hit the exposure switch, you got to hold down the rotator switch as well. So using a grids absorb scattered radiation. The grid ratio is the height of the lead strips versus the width of the spaces in between them. The higher the grid ratio, the more it absorbs photons. The bucky is a moving grid. It helps to reduce the grid lines. And a stationary grid doesn't move. Grid cutoff is the excessive absorption of radiation when the grid is malaligned. So the central ray you want it in the center of the grid at all times. And if it's shifted over, you're going to get too much radiation to one side of the image, which causes blurred edges and reduced contrast. So you always want to center the grid. If you put the grid backwards, the image will appear too light with visible grid lines. So the grid ratio, anytime you add a grid, you have to increase your exposure. So if you add a 5-to-1 grid, you're going to double your exposure. If you add an 8-to-1 grid, you're going to multiply by 4. In a 12-to-1 grid, you're going to multiply by 5. So 2, 4, 5 for 5, 8, 12 grids. For 12-to-1, so if MAS is 2 with no grid, and then you jump up to a 12 grid, MAS is now 10. You usually use that for a chest. And then reverse, if you could use a 12-to-1 grid at 40 MAS and you take the grid away, that would be an new MAS of 8 divided by 5. So using a grid, you have to increase your exposure. So body shape in X-ray, hyperasthenic is the fat. Sthenic is normal size, hyposthenic is skinny, and asthenic is very, very skinny. So hyperasthenic is fat. You may need to rotate the plate to get the full anatomy of the chest. Large patients, you need to increase 8 kVp, most important adjustment in body habitus. So the kVp, really think about body habitus going up and down. Increase penetration of the X-ray beam. The male pelvis is narrow and heart-shaped. The female pelvis is broader. The pubic arch angle is greater than 90 degrees in the females. And then in terms of planes, the sagittal plane divides the body into right and left halves. The coronal plane is anterior and posterior planes. Moving on to radiation safety, talk about maximum occupational exposures. 5,000 millirem equals 50,000 millisieverts, or I'm sorry, 5,000 millirem, 50 millisieverts, 0.5 grays. So you take away 2 zeros and 3 zeros. So 5,000, 50, 0.5 millirem, millisievert, and gray. So 5,000 millirem, 50 millisieverts, 0.05 gray is the maximum occupational exposure yearly. The cumulative dose over years is the person's age times 10 millisieverts. To undergo a blood changes, you would have to have a dose of 250 millisieverts. A chest X-ray is 0.1 millisieverts, so it would be the equivalent of 2,500 chest X-rays. 3,000 millisieverts can cause 50% death. Most occupational exposure is far less than this allowable. The exposure at the waist under a lead apron does not normally exceed 10 to 20% that received at the collar outside of the apron. So the dose meter should always be kept at the collar. A lead shield blocks 95% of scattered radiation. The gray is the unit of absorption, tissue absorption. It's the absorbed dose. Gonadal shielding reduces exposure by 90%, and it has to be 0.5 millimeters thick. The lens of the eye is the most sensitive. They just reduced annual exposure from 150 millisieverts to 20 millisieverts to reduce cataracts. And again, 250 millisieverts affects blood forming cells. Chest X-ray is 0.1 millisieverts. CT scan is 7 millisieverts. Pregnancy, the allowable annual dose is 5 millisieverts per 9 months. So it's about 10% of the maximal occupational exposure. So more safety, the atomic level interaction responsible for biological effects is ionization. Ionization of water produces free radicals. Ionization of cells nucleus affects the cell function. Mitosis is the most sensitive phase of cell life. It's when the cell divides. So mitosis is the most apt to have effects on radiation. Rapidly dividing cells and non-specific cells are more sensitive. So early on in pregnancy, when they're rapidly dividing, they're non-specific. Bone absorbs more radiation than soft tissue. Limited to the general public, not around radiation. Annual dose limit is 5 millisieverts, so about 10% of occupational exposure. An unborn child limit per 9 months is again 10%. Collimation reduces the beam size and is the most important in reducing scattered radiation. Non-threshold radiation is considered radiation that can affect you at any dose. The general principles of radiation is linear, so the more you get, the more expected effects you'll have. Non-threshold, meaning that any dose can be harmful. So that's the general principle. Conservative approach to radiation protection is a linear non-threshold. Hair loss and skin reddening is a threshold at 2 gray. These are somatic effects. Ionizing radiation has sufficient energy to remove an electron from its orbit. Badges, the most common badge used today is an optically stimulated luminescence. It uses aluminum oxide radiation detector, used most of the time. So x-rays of the hand, finger, and wrist. No grid, finger at 50 kVp with an MAS of 1.5 to 2. So these are done PA with the obliques 45 degrees with lateral rotation. Lateral of the index finger, you can rotate it so that the lateral part of the index finger is on the receptor. The other fingers, you will have to just push them out of the way to minimize less OID. Again, the PA oblique is considered lateral rotation. Use a sponge to visualize on the obliques, the IP joints. You can't use the teacup to look at the fingers because you won't see the IP joints. Use the sponge. The hand, again, is at 50 at 2 to 3 MAS. Obliques are 45 degrees with lateral rotation. You can use the teacup position for the lateral. The thumb, the AP, you have to rotate the wrist. Usually you're rotating with extreme medial rotation to lay the thumb flat. The oblique is the basically oblique of the thumb is an AP of the hand, and the lateral of the thumb has medial rotation. To get a good PA of the wrist, you have to flex the fingers to flatten the wrist. And again, the hand, fingers, and wrist all done PA. So the hyper internal rotation of the thumb to get it closest to the receptor is actually considered a AP, not a PA. So AP of the thumb. So AP, the forearm is 60 kVp, 3 to 5 MAS. Forearm is done in AP, supinated position, lateral, the radius and ulnar are superimposed. The AP oblique of the elbow with lateral rotation is going to show you the radial head and the capitellum. With medial rotation, it's going to show you the coronoid process and the trochlea. So the radial head view is a lateral rotated view. So for the humerus, AP, and lateral, you want to use the Bucky 70 kVp, so up your mass to 12. Stop breathing and don't move on the image. The AP arm, the arm is abducted and the arm supinated. For the lateral view, you're going to flex the elbow 45 degrees and internally rotate. So the shoulder's done at 70 kVp, 10 MAS in a Bucky. The central ray should be aimed 1 inch inferior to the coracoid process for the AP. In an external rotation AP, you're going to see the graded tuberosity better. Internal, you're going to see the lesser. The Grashy is done at 35 to 45 degrees in the coronal plane on the image receptor to see the joint line. For injuries, you can use the transthoracic lateral, which has the affected body part against the image receptor. Unaffected arm is raised above the head. And the transthoracic, you can use slow, deep breathing. This technique effectively blurs the superimposing ribs and lungs to visualize the humerus better. The PA oblique view is considered the scapular Y view, where the Y view scapular is perpendicular to the image receptor, so it's basically straight down the body of the scapula. It's 45 to 60 degrees of the opposite shoulder from the receptor. So the clavicle views are going to be done in the AP direction. AP is perpendicular to the clavicle. There's two views, so you'll be doing an AP and then a AP axial. An AP axial is 15 to 30 degrees cephalad, so you're aiming up on the 15 to 30 degrees on the second view. You want to stop breathing, and basically that better shows the clavicle away from the apex of the lung. For the PA of the scapula, you're going to abduct the arm like you're throwing a baseball at 90 degrees and 90 degrees. The lateral view of the scapula is the same as the scapula Y view. That's 45 to 60 degrees angled of the opposite shoulder. away from the bucky. The central ray on the AP scapula is mid-scapula, about 2 centimeters below the coracoid. AC joints are typically done with bilateral and with and without weights to determine the separation of the AC joint. Breathing techniques for the spinal views: the cervical spine, you should stop breathing, don't move. The AP thoracic, suspend breathing on expiration. So that's the AP. On the lateral, you can allow shallow breathing, which obscures the lung markings. Lumbar spine, stop breathing on expiration. So basically that lifts the diaphragm and gets the diaphragm away from the lumbar spine. On expiration, the diaphragm is high. The lung tissue is more dense without air, helps lift away from the lumbar spine. So the only difference is on the lateral thoracic, you allow shallow breathing. Otherwise, you stop breathing. Chest x-rays are done in the PA position, anterior surface against the bucky with the arms extended, oftentimes above or below, with the arms flexed at 90 degrees, hands to the hip or above the head. This is to rotate the scapula away from the lung field. Central ray is just above the C7 spinous process. Again, center around T7, inferior border of the scapula. SID is 72 inches. Take a chest x-ray on inspiration. Take two inspirations, hold for a second. It lowers the diaphragm. You can count 10 ribs. The left side of the chest x-ray on the cassette at all times on the lateral. If it was the right side, the heart would be magnified more. The chest x-ray is always done PA view. Patients' arms are raised overhead to take the scapula out of the view. The sternoclavicular joint should not be rotated. The right lung has 3 lobes. The left lung has 2 lobes. The carina, where the right and left lung bifurcate. Foreign body is most likely to go into the right lung because the carina is shorter on the right. So foreign body in the right lung. There are 5 ribs that are true ribs, and the next 5 are false ribs. They don't connect to the sternum. On the oblique views, the side of interest should always be closest to the image receptor. So the right posterior oblique looks at the right posterior ribs. The left posterior oblique looks at the left posterior ribs. For the anterior ribs, the right anterior oblique looks at the left ribs. The left anterior oblique looks at the right ribs. Spinal landmarks: C1 is going to be at the mastoid. C2-3 is the angle of the mandible, otherwise referred to as the gonian. The C3-4 is at the hyoid cartilage. C5 is the thyroid cartilage. C7-T1 is at the vertebral prominence. C7, the prominence of C7. T1 and T2, T1 is 2 inches above the jugular notch. T2 and 3 is at the jugular notch. T4 or 5, sternal angle. T7, inferior angle of the scapula. T9 and T10 at the xiphoid. L2, L3 at the inferior costal margin. L4, L5 at the iliac crest. S1 and S2 at the superior iliac spine. Coccyx at the pubic symphysis and greater trochus. Landmarks again. External auditory meatus is above the dens. The mastoid tip is C1. The gonion of the jaw, the mandible angle C3. Thyroid cartilage C3-4. Top of shoulders is 6-7. Jugular notch is 2-3. Sternal angle 4-5 of thoracic. Manubrium is mid-thoracic. Xiphoid tip is T10. The 10th rib, lower costal margin, is L3. L4-5 at the iliac crest. S1, S2 is AS-IS. Pubic symphysis at the coccyx. So the technique for the cervical spine is 75 to 85 kV in a grid with 8 to 16 MAS. AP should be 40 inches. SID, lateral is 72 inches SID to account for the increased OID. You center over C4 on the thyroid cartilage, and you're going to angle up 15 to 20 degrees on the cephalic tilt, so cephalic toward headward for the cervical lordosis. AP, the chin is slightly extended. For the odontoid view, the open mouth, drop the lower jaw, align the bottom of the teeth with the base of the occiput. Be careful not to hyperextend the neck. Obliques, center at C4 with a 15 to 20 degree cephalic tilt, 45 degrees of rotation, extending the lower jaw to avoid superimposition of the mandible, 72-inch SID. RPO demonstrates the left intervertebral foramen, whereas the LPO demonstrates the right foramen. Eyes shouldn't be in the light field. Again, the cervical spine centers over C4. You take it with expiration to help relax the shoulders to visualize C7, which drops the shoulders. Demonstrates the spinous processes and cervical facet joints. Cross-table lateral for all trauma cervical films. The trauma lateral is usually the first image. The swimmer's view center over C7 and T1. The odontoid view is, again, with the mouth open. Thoracic spine, center over T6, T7, midpoint of the sternum. Use KV about 70 to 80 with an MAS of 25 to 40. There's 12 thoracic bodies. The AP, the SC joint should be equidistant from midline, so there's no rotation. You can use the anode heel effect to minimize thickness variance by placing the patient's head to the anode side. The text left with intensity will be the brightest at the cathode side, where the part is thicker. So you want the thicker part towards the cathode side and the head towards the anode side. Lateral midcoronal is in the midcoronal plane. A breathing exposure may be used to blur lung densities and expose the patient after they exhale, so it's just shallow breathing on the lateral view. Swimmer's lateral, center over C7 and T1. You rotate the arm anteriorly, and the posterior junction of the cervical and thoracic vertebrae at C7 T1 is visualized. The costo-transverse joint is a small synovial joint where the tubercle of a rib connects with the transverse process of the corresponding vertebrae. So the technique for the lumbar spine, the KV is set at 7 to 80. The MAS is 35 on the AP, but then goes up to about 50 on the lateral. Obliques are around 40. Lumbar spine is centered mid-sagittal plane, CR at L3, L4, or 2 inches above the anterior superior iliac spine. L4 is at the crest, center higher to get to L1. AP spine is closer to the plate. Raising knees helps open the joint spaces. The PA opens the joint spaces normal on the lordotic, or the PA looks better on the joint spaces because of the normal lordotic curvature, which is basically the paradox of the X-ray beam. AP and PA shows lumbar bodies, disc spaces, and transverse processes, where the obliques, which are angled at 45 degrees, show the facet joints, apophyseal joints, and 30 degrees angulation for L5S1. Obliques for superior and inferior articulating processes. AP should include SI joints down to near the top of the pubic symphysis. Again, the lumbar spine is centered over L3, 2 inches above the iliac crest. Left side closest to the plate shows the intervertebral foramen of L1, L4. You want to suspend breathing on expiration. L5, S1 spot view. You want to set center line between the midcoronal and anterior superior iliac spine. You want 1 to 2 inches more posterior than the lateral of the lumbar spine. So just move slightly posterior and move 2 inches inferior to the iliac crest. You may need a caudal tilt 5 degrees so aiming down 5 degrees in males, 10 degrees in females to get the spot view. So just move down a little further. The Scotty dog view, the nose is the transverse process. The eye is the pedicle. The neck is the pars. The ear is the superior articulating process. The front leg is the inferior articulating process. And the tail is the superior articulating process because of the obliques. Next is the pelvis and SI joint technique, 65 to 80 kV, 20 MAS around. The pelvis, top of the receptor at the iliac crest. You want internally rotate the extremities 15 degrees. For the sacrum, it's 15 degrees cephalad. The center of the midpoint between the anterior superior iliac spine and the pubis. The lateral is perpendicular to the anterior superior iliac spine, 1 inch forward from the posterior sacrum. The coccyx is flipped. It's actually 10 degrees caudal, center between the ASS and the pubis. Because again, the coccyx comes back around and points forward. So you need to aim down on the image. The SI joints, you center 1 inch medial to the anterior superior iliac spine. And it's a 25-degree oblique with the side of interest elevated to get that AP. The sacral tilt is higher in females, 35 degrees. In males, 40 degrees in females when standing. So sacral tilt is higher in females. So technique for the femur and the hip, 80 kV at 12 MAS. Use the bucky. The AP of the femur should be the epicondyles parallel to the image receptor. For the hip, it's internally rotated 15 degrees to make the hip parallel with the image receptor. Hip and pelvis, again, legs immediately rotated to put the femoral neck in profile. A frog leg lateral is when the hip is flexed and abducted 45 degrees. The femoral head is located between the anterior superior iliac spine and the symphysis pubis at the midpoint. So the technique for the knee is 20 MAS at 80 kVp. You have to use the bucky. AP is a ½ inch distal to the apex or the bottom of the patella. So the apex is the bottom of the patella. So aim low, ½ inch lower to the bottom. The lateral knee, the knees flex at 20 to 30 degrees. Angle up 5 to 7 degrees on the lateral. Angle up cephalad. The central ray 1 inch distal to the medial condyle. The condyles should be superimposed. And the knees flexed at 45 degrees. You need to increase your MAS if you angle the x-ray beam up to 50%. So for the ankle and lower leg, 60 kV at 5 MAS. The AP is dorsiflexed. The dorsiflex for the AP and oblique to see the mortise view. AP oblique, the mortise in a 20-degree internal rotation. So the mortise view is 20 degrees of internal rotation where the malleoli are parallel to the receptor on the mortise. And then you do a 45-degree oblique, which shows the tib fib joint best. On the lateral, you want to bend the knee and do a lateral where the malleoli are perpendicular to the beam. And the tib fib, you want to put the film the long way to get to hold both bones. And again, the lateral view, the lateral side of the foot is on the receptor, so you're shooting at the medial side of the ankle on the lateral. So the technique for the foot and toes, 50 kV at 2 to 4 MAS. For the toes and foot, it's CR is 15 degrees posterior toward the heel. So aim it posterior towards the heel. The oblique, you're rotating it 30 degrees, medial rotation. So again, AP foot 15 degrees, oblique medial rotation 30 degrees. For the lateral, you have to dorsiflex the foot perpendicular to the tibia. Light field should be 1 inch past the calcaneus and toes. Wedge can be used to create more even density, the thicker wedge over the toes to prevent overexposure. And then the calcaneus is done at a 40 degrees cephalad towards the head on the apiaxial view.